Hi, everybody. I'm Dr. Chen. I am the Chief Population Health Officer at Catalight, and today we're going to talk about the clinician's influence on social drivers of health.
Hi, everyone. I'm Brianna Fitchett. I'm a BCBA and have a master's in public health, and I'm a VP here at Catalight. And I'm really excited to talk to you more today about social drivers of health for our populations. All right, so let's start with our learning objectives. So today we have three main areas that we want to make sure everyone leaves feeling really prepared for and able to talk about. So the first is identifying and describing 5 domains of social drivers of health. Being able to describe specific ways service providers or clinicians can impact and improve outcomes by focusing on social drivers of health, or SDOH, as we like to call them for short. And then creating changes in practice to improve SDOH for the people that you serve.
So first, let's talk about health. Health is actually made up of 3 components, right? And I like to simplify it to behavioral health, physical health, and social health. And behavioral health includes actually 2 components: individual behaviors, as well as the type of treatment or therapy that people are getting, right? And those 2 will influence somebody's behavioral health. Physical health is influenced by genetics, so what somebody is born with. And then it's also influenced by healthcare, what type of access to healthcare they have, what quality of healthcare they get. And those will influence their physical health. And the last and third contributor to overall health is social health. And that includes the physical environment and the social environment that people live and function in. And those 3 things together will influence overall health. Now, health in the IDD population and health outcomes, rather, are different. And I'm going to share with you in the next few slides how different health and health outcomes are for adults with IDD. So we know, and there are many, many studies that have shown that life expectancy in adults with IDD is shorter than adults who do not have IDD. Now, before the pandemic, it's interesting to note that the life expectancy among those with IDD was actually improving slowly, but improving. And the pandemic obviously had an impact on that. Now, what we do know in the right side of the slide, we see some data on how much shorter those with IDD live. And those with intellectual disabilities have an approximately 12-year shorter life expectancy. Those with Down syndrome specifically, 18 years shorter. And then those with cerebral palsy, 23 years shorter. So these are substantial numbers and really a call to action, right? That we have disparities in outcomes in those with IDD. Next, we look at adults with cognitive limitations, again, so IDD, and we know that they also have a higher incidence and prevalence of diabetes and actually many other comorbidities as well. When you look at hypertension, vascular disease, the stroke, there are many other comorbidities that adults with IDD have. And this, no surprise, will contribute to their shorter life expectancy. And so, thinking about these data, right, we think about how we can influence these outcomes. So what are the elements of prevention? What are the elements of maintenance if someone already has one of these comorbidities? Syndrome have a higher risk of leukemia, and that's just an innate to the genetic makeup. However, beyond genetics, right, we know that adults with IDD face barriers to diagnosis, and also just their all-cause mortality is higher, and this has been studied in multiple different types of cancer. And so disparities also here in cancer outcomes. Now, looking at dementia, I think it's been known that those with Down syndrome do have a lot higher prevalence of dementia. However, this is also true in the ID population, that those with cognitive uh, disabilities actually also have a higher prevalence of dementia, as you can see in the green bars on this chart. And this has, great implications, not just the dementia itself, but knowing that the same population has higher incidence of the other comorbidities such as diabetes and hypertension, the dementia will interact with their ability to manage the rest of their health and the rest of their comorbidities. So this is an important data point. Now, putting all the medical and healthcare together, unfortunately, that only influences 20% of somebody's health outcomes, right? Of all the things that go into what influences a health outcome, again, only 20% is influenced by medical care. The other 80% is influenced by health behaviors. And in fact, a whole half, 50%, is influenced by socioeconomic factors and physical environment. And so this is when we'll make a transition in our talk to talk about social drivers of health, which really influence that 50% of a person's health outcomes.
So like you were saying, social determinants or drivers of health, they're really the conditions of the environment around us. They are where people are born, live, learn, work, play, worship, and age. So really every aspect of life is included in social drivers of health. When you look here, there's 8 kind of main categories, if you will, or 8 main drivers: food, housing, transportation, health behaviors, violence, education, social support, and employment. And all of these play a role in someone's health. Today, we're only going to talk about 5 of those. So we're going to really hone in and focus on health literacy, food, social isolation, transportation, as well as work and money. And so to dive in, we're going to talk about each one individually. So let's start with health literacy. Health literacy it's a really important one, and it's really important to understand the difference between health literacy and literacy. So starting out with just literacy. These are some really surprising statistics that I think are really important for everyone to understand, and especially for clinicians. So 21% of US adults have low to no literacy. And 54% of adults have less than a 6th grade level of literacy. These together really show the impact that this has on the populations that we're serving, the families that we work with. And really interesting, at least for me, I'm based out of California, is that California has the lowest adult literacy rate in the country. Health literacy is the degree to which an individual has the ability to find, understand, and use the information to inform health decisions. So really, when I boil that down, I think of it as health literacy is the ability of someone to be able to understand what's going on with their health, talking to their practitioners, and then advocating for themselves. Or if it's for a family member, advocating for their child's needs. As a clinician, as a practitioner, it's really important that we are taking this into account and implementing strategies to make sure that we're improving and supporting our families, our clients, our patients' health literacy. It can be as simple as not using jargon, making sure that the person that you're speaking to understands what you're saying, having them repeat back, using simpler terms or visuals if needed, and really making sure that what you're saying connects to the person and that they can then use that information to support their own treatment or the treatment of their child. Really simple things that we can do in our day-to-day clinical work that can have a really big lasting effect on our families and their future in advocating and talking about their health. Okay, so the next one is food insecurity. Again, some really startling facts that really put this into perspective. So 42 million people, so that's 1 in 8, as well as 13 million children, so 1 in 6 in our country experience food insecurity. That's a really big number when we think about how many clients you might work with on your caseload or how many patients you see. Probability is there's a high number of those clients that we work with who may be experiencing some sort of food insecurity. There's also different levels of food insecurity. So when you look at the very bottom of this period, so very low food security. So eating patterns are disrupted. The household lacks money or other resources for food. These could be families that need to access food banks, families who really need a high level of support to get access to the foods that they need. And then we go up from there, all the way, low food security, marginal to high. So again, relating this back to the actual clinical application, it's really important that this is a talking point, especially during treatment planning for clinicians. A lot of times as a behavior analyst, I've had families who have asked for food sensitivity goals. And typically, we want to make sure that we're working with the family, working with the child, thinking about the person's autonomy and making decisions about the food that they're eating. But it's also really important when families ask about that, to ask about the reason why. It could be that a family is asking because they only have access to food from a food bank, and maybe it's not their preferred foods. A lot of children with IDD and individuals with IDD have very strong food preferences, food sensitivities, potentially around texture, color. So it's really important to understand what is going on in the family's life around food, so that we can make sure that through our treatment planning, through our goals or the different things that we're focusing on the right areas to support families in improving their food security in whatever way that we can. The next one is social isolation. So this one really dives into how meaningful social determinants or social drivers of health are, and how it impacts the rest of our health. So just looking at these statistics here, loneliness and social isolation can increase your risk of early death by 25%. Cardiovascular disease, stroke, 30%, dementia, 50%. So when we think of these, and then we think about what Dr. Chen was speaking to before about our population for those with IDD, we're stacking, all of these different percentages up basically upon, each individual with IDD, which is really increasing their risk for some really serious things, all the way up to death. So social isolation is really important that we're thinking about as clinicians and that we're addressing. We have the ability to support behavioral strategies, independent living skills that can increase community access. It's really important as a clinician during the assessment and ongoing during treatment to be asking questions about what is socially fulfilling to each person. Every person has different activities, different situations that are socially fulfilling to them. And so making sure that we're finding out, what does that person want? What are they seeking? How did they get joy from social situations, so that we can program and we can be thinking about them throughout treatment. What is socially enjoyable for me is going to be different from the next person. So making sure that we're understanding what our patients want, and supporting them in whatever treatment methodology we're using to decrease their social isolation and their loneliness. Understanding someone an introvert and an extrovert, how does that play into it? All the different areas of social well-being really come together in treatment, and making sure that we're supporting our patients to decrease that loneliness and social isolation. Okay, work and financial insecurity. This one is definitely, this is a tough one. There's so much that falls under this because so many different factors all kind of come together into work and financial security. Um, a lot of times what I think about and what I talk to clinicians about is understanding how does the treatment or the course of care that I'm prescribing or working on with a client, how does this impact their life? So if it's a child, how do treatment sessions impact the family schedule? Are sessions at a time where parents have to leave work? Or, are families having to forego other activities, maybe take jobs that have hours that fit with treatment schedules to be able to make it work for their child. All right, transportation. So 3.6 million people in the US don't obtain medical care due to transportation issues. This is one that I think a lot of times us as clinicians kind of gloss over, oh, we don't have the ability to change anything for our clients or our patients. Transportation. We'll kind of meet them where we can. But really, again, it goes back to understanding the family's needs and asking questions. I don't think that as clinicians, we ask enough questions during our intakes, during our assessments to really assess and understand families' needs outside of treatment. So understanding, does a family lack access to a vehicle? Are they potentially sharing a vehicle and having to, work around a shared schedule? It could be things like inadequate infrastructure. This impacts families who live in urban areas as well as rural. How are families able to access care and get to different facilities as needed? Long distances, lengthy time. Again, both for urban and rural, a lot of times it takes, 2 hours to go 4 miles in a city, or it could take 2 hours to go 100 miles for those who live in rural areas. So really understanding the type of transportation issues and how we can support them through treatment. Obviously, there's costs for transportations, which can be prohibitive. And then there's policies that affect travel. So as clinicians, again, it's really important to understand what type of issues our families facing, and then how can we, through our treatment and our recommendations, support them better, whether that's through adding in telehealth options for families, or looking at how we schedule. Can sessions be scheduled at different times? Can sessions occur at a different cadence? Really looking at all the different ways that we can support families to decrease their transportation issues. So, kind of summing up here, our takeaways. So, clinicians can really impact social drivers of health in so many different ways. Absolutely. I think the number one thing is talking about it and asking questions. When we look at the different areas, so physical wellness, as clinicians, we can absolutely impact this. Making sure that individuals are attending their well child, their annual checkups, thinking about physical causes for behavior. So, as a behavior analyst, if a new behavior pops up, I always want to make sure that I'm looking at potential physical causes. Is the child sick? Is there, potentially an ear infection? Are they exhibiting um, stomach issues? There's so many different things that could be impacting behavior. So really ruling out those physical ones before moving on to behavioral. Health literacy, not using jargon, using a second grade reading level in any type of shared document. Repeating back, making sure families truly understand what you're talking about before moving on. For food insecurities, like I said, asking questions, understanding what's going on and what potential food insecurities the family's facing, referring them to a case manager if there's one available. Um, as well as communicating with the rest of the medical and behavioral team, connecting that continuity of care, making sure everybody's working on the same team. Understanding time constraints, schedule, costs, and then referring clients or parents to work programs. All of those together really address food, work, and financial insecurities. For social isolation, treatment planning to support the individual's social happiness. Again, what does that mean to them? What makes this person happy, and how do we support them in achieving that? And then finally, with transportation, talking about the barriers to accessing care, offering telehealth, being flexible with schedules, locations, and really understanding the types of transportation limitations that a family might be experiencing.
Okay. So now we're just going to move on very briefly and talk about why collecting social drivers of health data is important and all the different levels that it carries importance. So there are three basic steps in collecting the data. First is just to describe and understand and make a list of your screening questions, right? What do you want to collect? As Brianna mentioned, there are many different social drivers of health. And first, you and your organization, so maybe it's you in an individual practice, or maybe you're making decisions with and for many providers. The first step is just deciding what you want to collect and how you're going to ask the questions. So then we move on to provider awareness. And there's three pieces to this. First is the providers, the people who are engaged in asking these questions and collecting the data need to understand why you are asking the questions and what will be done with the data. How are we going to use the data to actually help clients, patients on an individual level, or will it be at a group or community level? So those are the two key pieces. And then providers, because they are in the front lines and they are the ones interacting with the patients, they often have ideas and meaningful ideas on how to operationalize collecting the data. And so this is a great time to ask about operational suggestions and to move on really to the third arrow, which is integrating the data collection into workflow. And the decisions here that need to be made are around who's going to ask the questions, right? Who's going to answer the questions? Is this going to be on a survey that's digital? Is this going to be on a piece of paper in the waiting room? Do we want clients and patients to answer it themselves? Do we want perhaps a family member to answer for them? So ferreting all that out will help with the workflow. We also know that some questions are sensitive. Brianna mentioned, quite a few sensitive topics. And so those may not be appropriate in your setting to put in a survey form. That those may be something that you want to get answers to in a dialogue, in an intake assessment or intake interview. Electronic versus paper is always, a great question. And obviously, the more electronic, the better. It's easier to get data when it's input electronically. However, in some settings, that's just not going to work. And so devising a paper form that is amenable to easy filling in is what would be recommended. But again, every setting is different, and these are sort of three basic steps on how you would get to the point of data collection at your organization. And then what happens to these data? How is it meaningful, right? And it can be meaningful at so many levels. So at the individual client and family level, right, asking these questions and collecting these data tells the family that you are interested in a holistic assessment of their situation. So not just their illness, not just their condition, not just the reason they are coming to you, but really the entirety of their environment is what you're interested in, because we know that will impact more than 50% of their health outcomes, right? It also allows you to use the data that you collect to tailor the treatment. And Brianna just spent several slides talking to all of us about how we can tailor treatment to different social drivers of health. It also helps build trust with the family. And lastly, you can connect families to resources once you know what needs they have, connecting them to community resources that you and your organization know about could be life-changing for a family. And once you treat many families and collect data on many families, you start getting a very good picture of the community, right? What's going on in the community and what does the community need? And that then drives funding. It drives the development of support programs. And this will then ultimately allow us to go to the third section on the right, which is to help drive policy and regulation, drives what Medicare and Medicaid might cover in the US and other insurance programs in other countries, public insurance, and also helps drive what benefits people with IDD can get access to. So as part of the discussion with the frontline, right, with the providers on, hey, we're going to collect the social drivers of health data, the real reasons for it that are very tangible and immediate are on the left side of the slide of being immediately able to help our clients. But all of that aggregated becomes very powerful to actually help the community.
Thanks everyone so much for joining and listening to us today. We really hope that you can stay connected to us. It was great talking to you and sharing a little bit about our work and about social drivers of health. If you have any questions, here's our emails. Please don't hesitate to reach out. Thank you.